Okay. Thank you so much, Hudson. Hi, everybody. My name is Andrea Flincham, and I am your HAI coordinator at the Department for Public Health. And I just want to welcome you all to this part 2 of our learning about the OSHA ETS and translating the ETS into practice, a specific formidable operational plan. We are tickled to death to have the Center for Education and Training and Infection Prevention at the University of Louisville as partners in our training and education endeavors for you guys. And I know that you will enjoy today's session. So without further ado, I will turn it over to Hudson and Sarah. Thank you.
Awesome. Thanks very much, Andrea. Sarah and I are excited to be back with you for our second in a series of what I think Sarah and I have said is going to be at least 3 of these programs. So we'll continue to add more on. And we're also glad to have Dr. Spicer from the state join us as well. So thank you for all making time for us today. As always, we're going to be offering continuing education for today's program. This program will be worth 1.5 hours if you stay on for the full duration. You do have to attend 90 minutes, including the question and answer at the end. And then you'll receive an email from Terry Goodman and Associates to complete your CE evaluation. I think we introduced ourselves last time, but if you're not familiar, quick introduction. Sarah and I work with the University of Louisville School of Medicine in the Center for Education and Training and Infection Prevention. Sarah has a very long background in infection prevention, amongst many other things. And I work with Dr. Ruth Carricosa to Sarah, and she'll probably be popping in here as we speak today. So here's just a little bit of additional background about Sarah in case you didn't catch it before. There she goes with her wave. And your certificate will be available for download as soon as you complete the online CE evaluation, which should go out by Friday of this week. At the very top of that page, you'll be able to generate a PDF and you'll be able to download that for your records. Here are our disclosures. You can see mine, and Sarah has none since we're offering continuing education for today's program. And we're really going to jump right in. So on the last program, there were a couple of different requests about sort of diving in a little bit deeper into the granularity of this ETS and understanding sort of how to operationalize this and what to do in specific settings. So at the very beginning of the program, I'm going to cover some of the, I would call them more legal nuances associated with this standard. And then Sarah's going to walk us through what I think is probably the most important, which is some of the operational elements of that plan and what does that need to look like. And then we'll conclude with some samples of what that needs to sort of be at the very end of the program. So let's sort of think about how this impacts us on a local and a state level, right? If we looked at COVID in general, we've known that there's been things that have superseded or different regulations based on certain state, things that have been primarily through executive order. And so the OSHA ETS understands that there's going to be a little bit of a nuance associated with that. And essentially they want it to be the state or the local regulation needs to be at least effective, right? As that OSHA ETS, which makes sense. So we're trying to not go a level below that OSHA standard, but we certainly don't want to take it and go crazy with it, if you will. So what about fully vaccinated healthcare providers, right? This is a very tricky situation for a lot of different reasons. If you turn on the news every day, this is another conversation that's being had about more and more health systems, especially that are moving to fully vaccinated status. I know University of Louisville, for example, is going in that direction as well. And so we'll probably see more and more of this, and it won't just be in the healthcare sector. We'll probably also see this equally so in the private sector, especially as the Food and Drug Administration issues that full licensure, which is expected for Pfizer and Moderna to be pretty soon. And so certainly we'll think about that. But the standard itself, right, is really going to apply where healthcare services are delivered, right? And there are going to be instances where you'll see that OSHA uses the sort of answer, it depends, which sort of makes me laugh because my brother's an attorney and half the answers he ever gives me are, it depends, right? And that's where I think they make their money. But we know that we are trying to do the best possible job to protect the masses of individuals, both our patients as well as our healthcare colleagues. A big sort of instance that we have going on is we do have a lot of healthcare workers that are not vaccinated. And so we've got sort of that patient protection responsibility that we're balancing with, what is the employee willing to do and what are they not willing to do? What is the employer willing to do? In some healthcare instances, we know that there's going to be settings where you may not be able to do a mandate because you simply can't staff the building as it is currently, right? And so every facility is going to look at this a little bit differently. One of the other things that you'll notice too is that even if you do have somebody that's fully vaccinated, it's not to say that we don't want to continue to take the necessary precautions to protect them. We still want to do that, especially as we see more and more breakthrough infections. And we'll expect that number to go up as more people get vaccinated, right? So as we have a higher vaccinated population, which is fantastic, it would only make sense from an epidemiologic standpoint that we will continue to see more breakthrough infections. Luckily, the majority of these infections are not very, very serious in nature, which is exactly what we're trying to do with these vaccines, is to prevent that serious illness and hospitalization and associated death. So what about sort of fully vaccinated? Well, we know that CDC's definition, right, is that fully vaccinated is 2 weeks following that final dose of whatever that vaccine is, right? So if it was J&J, that's going to be that single dose. If it's a Moderna or Pfizer, it's going to be that 2-dose mRNA series, right? And so one of the things that you've got to think about in your plan is, how do I define what vaccinated is? And you want to use that CDC definition. One of the other things, and Sarah will sort of talk about this in sort of the headings of the plan, is how do I verify that, right? If I'm going to have, let's say I have a fully vaccinated workforce, well, that's fantastic. But how do I verify that? How do I make sure that that is truly the case? And then as we get more and more clinical data, how do we understand when sort of those vaccines are going to be less and less effective over time? Is it 6 months, 8 months, 10 months, et cetera? And so our policy and procedure must include a way to determine the employee's vaccination status, right? That may be accomplished through a lot of different means. And you'll find that with things like visitation and screening, that OSHA gives us a lot of flexibility in how we sort of tactically accomplish it. So they sort of say, here's what the end goal is, but how you do it within your institution or your health system is really completely up to you. And so it gives us a little bit of flexibility to make sure that it's personalized for that. Now, there are a few exceptions that we'll talk about, right? One of those is really around, well-defined hospital ambulatory care settings, right? So if you've got all your employees are fully vaccinated and anyone who comes in is going to be screened, right, then this is not going to apply. We also have an exception with home healthcare settings, right, where you have all of those employees, those healthcare workers that are fully vaccinated. And again, anyone that's going to be interacted there is going to be screened prior to entry, which that can be a little bit challenging, especially in the home health environment, right? And one of the big premises of this ETS is there a reasonable expectation of exposure to COVID? So for example, one of the common questions is, what about my offsite billing office? Is that considered a healthcare facility? And the answer is no, right? There's no reasonable expectation that there's going to be contact with someone that has COVID. And so we have to think about that. But there are other exceptions, like a blood mobile that may be a mobile transport unit that's out in the community, and that would follow within the OSHA standard specifically. So what about some other vaccination things that we got to consider, right? There are going to be a few things that will come up, particularly with employees that either have known history of anaphylaxis, they've got some type of reaction that's noted in their chart, maybe they're severely immunocompromised and their healthcare provider says, we're not willing to give you that vaccine right now in your current state of immunity. And so these are all things that we, again, have to have on our policy and procedure that allows us to make that determination, to document that exception, and then take the reasonable and prudent steps to protect that person, but also any patients or other colleagues that they're interacting with. If we look at the great CDC chart that they have, and I can't remember what page it's on, but on their website, they sort of talk about the different risk factors associated with comorbidities. And we know that sort of the immune response in immunocompromised individuals to a vaccine can be very different, right? And so there may be some individuals that also are not going to be great candidates for the vaccine for whatever reason. But the most, the majority of the people that we're dealing with will, right? And when we're doing sort of this, reasonable accommodation, that's going to really think about things like, can I put them in a mask permanently? Do they need to wear a respirator? Can they, telecommute, or can they do telemedicine? If you have a physician, for example, that is able to do telehealth and is not vaccinated for whatever reason, well, then they can still continue to do that job. They're just not seeing patients in person, right? So there are some ways to think about that to make sure that we can still accommodate individuals. So what about home health settings, right? And again, this is where it gets a little bit, challenging when you have different types of settings, right? And I'm going to sort of read some of the verbiage here because I think it's important to look at the nuance that they have, right? So if you're going into private residences or other physical locations, right, controlled by other persons, right, then you have to have policy and procedures in place to protect those employees. So essentially what they're saying here is that if I'm going into a private residence or home, right, and I don't have control over that environment, then my plan must dictate what are the necessary steps for me to protect myself. And I'll give you a perfect example. I have a dear friend over in Alabama that actually works as a physical therapist, and she primarily does home visits. And she has had a ton of COVID patients. And she repeatedly asked to have respirators provided to her. And her employer said, we don't have to provide that. You only need a surgical mask, right? And so this would be an instance where that plan would dictate, because you're going into that setting, and even if they're not confirmed COVID, maybe they're suspected or they've had an exposure, then we want to arm our employees, right, with the necessary personal protective equipment in order to do that, right? So that's something to really think about. So what about employee input? So again, Sarah's going to sort of walk through the core elements of the plan, but one of the things that rightfully so is in the OSHA ETS is that before we go do anything, we want to get input from the frontline employees that are really going to be implementing this and actually living this policy. If we develop this at the executive level or at the infection prevention level alone, it doesn't give us the level of granularity that's needed to personalize this. And so we want to get representation from as many of the different functions as possible that are going to be part of that hazard risk assessment, right? And then as we develop and implement that plan, we can use those folks as our sort of barometer in the field to say, is this working? Is this not? Do we need to refine something? What is, sort of your experience with this? How are the patients seeing this? There may be union issues involved as well, right? And so there are different modalities that we can do this. We can certainly do this with in-person meetings, Zoom like we're doing now. You can have comment boxes. So again, OSHA is very flexible on the means for accomplishing this, but they want you to document that there was an employee input process, right? And it totally makes sense. I mean, if we did this for all things in healthcare, we'd probably be in a much better position. So what does that hazard component or assessment need to actually have as its core components, right? Well, first of all, we want to look at the types of setting that we're going to be in. Is this home health? Is this an inpatient hospital? Is this long-term care? Is this, an ambulatory surgery center? What is it? And what are the most common specific hazards or risk factors that we're going to probably deal with, right? And then from that, we're going to sort of develop our plan to do risk mitigation to abate those hazards, right? We want to include in there the date that that risk assessment was performed, right? The names and the titles of the individuals that participated, again, to show that this was done in an interprofessional style, right? We don't want to have one single individual that's looking at it through their personal lens without input from others. So certainly an infection preventionist, somebody from nursing, somebody from the medical staff. Engineering is a great one to have involved. Sarah actually got some great slides in here about sort of looking at the particle size that a lot of folks just don't understand that. And so we provided that as a reference. If you identify a risk alone, that's not necessarily bad unless we don't address it through mitigation. And so as we identify a risk, that sort of next block over needs to be, here's the risk mitigation that we're going to take. What are we going to sort of do? How are we going to monitor effectiveness? How often will we really evaluate that? And what do we need to determine success or failure associated with that? We can also prioritize these things. For example, if we have an area where there's going to be, a total COVID unit and we have very poor air circulation, well, we know that that's a big priority to get engineering to fix that, right? And so that's important that we do that. How are we going to communicate this information out to the stakeholders? Is it going to be through, signage on the units? Is it going to be through screensavers, emails, text messages? All of that needs to be there, right? And then lastly is your written documentation. Now, keep in mind, if you have an OSHA complaint, that's going to be one of the first places they're going to go, is to look and see what was your hazard assessment? How did you risk mitigate that? Did you follow that risk mitigation? And sort of how are you tracking your success and or failures associated with that? So one of the other areas that is certainly challenging, especially for large hospitals, is sort of looking at movement of people, right? And so we've got that hazard assessment that has got to look at all of the different aspects of where that employee may potentially be exposed to COVID. So that may be the employee locker room, the break room, the cafeteria, obviously any clinical areas. There may be other areas that are sort of confined spaces like classrooms that we have to think about as well. And so that hazard assessment's got to look at all of those different pinch points and identify, what are we going to do about those? How would we risk mitigate that? Are there things that we can do to improve air circulation as an example? And we're going to hear so much more over the next few months, I'm convinced, about HVAC system. Sarah and I were actually talking about that a little bit earlier today, about how valuable of a topic that is, one that we'll probably dive a little bit deeper into in our third webinar in this series. Now, the other thing to think about too is as employees enter and leave a facility, is there an area of congregation? What about in cafeterias? And so if we've got sort of those pinch points, again, we want to focus in on those. And then as much as possible, we want to address how people can enter and leave, try to limit that as much as we can. Now, certainly there may be logistical challenges associated with that, but if you can sort of funnel people through a certain entry and exit point, then that makes it a lot easier from a risk mitigation standpoint. Now, one of the things that's in that ETS, and we talked about this very briefly on our last program, is sort of the role of that COVID-19 safety coordinator, right? And that is a person that's got to have sort of knowledge and authority. That's sort of the way that I look at it. They can't be somebody who's just going to walk around and say, well, bad, 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 you can't do that, but have no sort of teeth that they can exercise when needed. And really our goal is not to be punitive, but to really be rewarding of good behavior and to remind people of what's expected, because I'm really convinced that especially right now, resilience is just so low that a lot of people just don't have a clue what they're doing half the time anyway, because they're so tired. And I can certainly relate to that as well, right? So certainly this is an individual that needs to have some basic working knowledge of infection prevention and control, but they don't have to be the infection preventionist. They also need to understand that sort of clinical setting. Do you necessarily want to take a long-term care nurse and put them in a hospital and ask them to do this? No. And vice versa, that clinical care setting is going to be very, very different. But the key here is they've got to be able to take those corrective measures. Now, in the plan, that individual has to be designated, right? And so the employer is going to define sort of what those roles and responsibilities look like. But part of that is going to be to drive the plan, to make sure that you sort of lead that, hold them accountable, conducting inspections as an example, and then really providing that feedback to all of the different stakeholders across the building. So what about screening? Recently, my brother was actually in the hospital, and I went down to the emergency department where he lives, and was trying to get in, and it was quite a process. And I was a little bit surprised because I walked in and they had hand hygiene and they had masks, they had a thermometer and all these different things that were really looking like they were going to screen me. And I got finally up to the little desk, and they said, "Oh, we need your driver's license." And I said, "Well, don't you want to screen me?" And she said, "Oh, no, we're not really doing that right now unless you look symptomatic." And I thought the irony of that statement, unless you look symptomatic, especially when we know that some of these infections, especially with COVID, are going to be asymptomatic carriers. So what we're trying to do with screening is to limit contact as much as possible and to really identify quickly any individual that's going to either be at high risk for a recent exposure, or certainly that might be potentially infectious at this point, right? And so that sort of screening process can vary by institution. If you're screening employees, that may look very different than if you're just screening the actual visitors coming in and or the patients. A lot of healthcare facilities, for example, before they transfer, will also test a patient if they're sending them off to another facility. But one of the biggest things that we can do is have somebody down there at that screening sort of checkpoint that is really well versed in what we're looking for. Somebody that is able to sort of ascertain very quickly if somebody is answering those questions truthfully. Also somebody who is was able to sort of corral people so that they don't try to bypass that. There was a sort of horrible situation that I was aware of a few months ago where a physician came in and bypassed a checkpoint and actually went in knowingly, she knew she was sick, went in, actually had COVID, had contracted it from her home environment, and then proceeded to give it to several other physicians and a few patients, right? And so this is something that we just can't accept the consequence of. And so we want to be very, very consistent in how we apply that. So the type of screening, as I mentioned before, though, is really up to you, right? There's a lot of flexibility, right? But at a minimum, they want you to look sort of at asking questions for signs and symptoms of illness as sort of that core baseline, right? You may also have other facility requirements based on your local geography, your rate of community transmission, other things that you're trying to do. For example, a bone marrow transplant unit is probably going to have a whole host of other restrictions compared to the rest of a regular, med-surg unit, as an example. One of the other things that we have to consider is that individual following our existing policy and procedure. Just this morning, I had to go to an orthopedic surgeon to have my shoulder checked out. And there was a gentleman that walked in as I was sitting in the waiting room, and he literally had his mask sort of balled up right underneath his nose to just cover his lips. And I just, sort of internally shook my head and thought, here we go again, right? And so that requires somebody to intervene. And I watched about 5 different staff members, some of which were clinical, not say a word to this individual as they took him to the back. And so you've got to have somebody with the kahunas, if you will, that's willing to say, hey, let's get you, to put that mask on correctly so that we can protect our other staff members and our patients. So certainly want to think about that from that standpoint. One of the other things that we can do too is to sort of use tools and technology. You can use an app to screen people, especially for symptoms. You can do things where you can go out to the car as an example, right? There's a lot of different ways to execute this. And I'm seeing this done very, very heavily in a lot of corporate manufacturing settings that I've worked with, where they actually have automated screening kiosk, where you walk in, your temperature's taken, and ask you some questions. It also asks you if you're vaccinated or not to sort of direct those questions. And then it's a pretty simple process that's done in about 30 to 45 seconds. So if we think back to, at the very beginning of the pandemic, and I'll just sort of use myself as an example, I was very, very concerned about the respiratory protection, right, that was available. At the very beginning, this was before I had bought my own elastomeric respirator. And I remember walking into a hospital with a COVID positive patient that was going, there was an ICU to ICU transfer. And we were in, full PPE, you name it, we had it on. And we walked in, and I'll never forget, the screening person said, well, we need to screen you. And I said, well, this person's on a vent, they're not doing well, we really need to get to the ICU. And I said, but whatever, let's just get it done. And, she proceeded to say, well, we need you to take off those respirators and put on a surgical mask. And I thought, what in the world is going on here? And she said, well, that's what our hospital lets employees wear. And so there was obviously a discrepancy between what was really the policy versus what the screening personnel thought it was. And so they were asking me to essentially downgrade my respiratory protection with a known COVID positive patient. And that certainly was not going to happen. And so generally speaking, right, very much in line with what we would see with normal OSHA requirements specified in the bloodborne pathogen standard, the employer, right, has that responsibility to provide adequate PPE based on the risk, right? So if there's going to be that reasonable or suspected exposure, then the employer is liable to provide proper PPE. Now, that does not mean your preferred brand. It doesn't mean the most comfortable, but it does mean functional, right? And so we want to make sure that we're always, always, always providing functional PPE from that standpoint. Right now, CDC, of course, has got some exposure guidance about sort of the duration of time in the 6 feet, but we're going to, again, follow the OSHA reporting standards for purposes of this webinar. So one of the big questions that's come up frequently is, can an employee who says, I want to go out and buy my own respirator, can they actually wear it? Right? And the answer is yes, they can. And I think this is actually a really important thing to stress that I found a lot of employers don't know. I was one of these people. I brought my own elastomeric respirator. I had my own PAPR. I went through the fit testing process with occupational health, went through all of that voluntarily, but I was absolutely not going to let somebody control my destiny when it came to my respiratory health and protection. And so if an employer, right, is requiring an employee with a face mask, right, then they also have to sort of, permit you to bring your own respirator in, right? That respirator does need to meet the OSHA standards, but it does allow you sort of the flexibility as well. And Kathy, I see your comment in there, and I absolutely agree. So Kathy's comment was, makes you wonder whether some of the Delta spread is related to clinical staff lack of knowledge or common sense. I would say it's probably a combo of both, right? If there's one thing that we've all seen, and I think we can all agree to this, that there's just been a lack of common sense across the board. My absolute favorite continues to be the individuals that are in a car alone by themselves that continue to wear a mask, or outside in a beautiful outdoor field running, and they continue to wear a mask by themselves, right? And so we've got to think very logically and pragmatically about what really is going to make the most sense. How do we get our biggest bang for our buck? And most importantly, how do we protect our patients and our staff members? Any healthcare worker getting COVID occupationally from an exposure is unacceptable. And we want to do everything in our power to sort of, get that down to zero. So another thing that has been well defined, and I see we probably have a few people on the line today from the dental practice setting. So we've included some specific dental issues here, but open suctioning of airways is going to be an aerosol generating procedure. Sputum induction, which a lot of times is going to be done in the bronchoscopy procedure. Certainly if you're doing active CPR, there are ways to control that with a great bag valve mask that has an antiviral filter on it. Certainly if you're doing any type of endotracheal intubation or extubation, non-invasive ventilation, there are ways, again, to seal those circuits. I would encourage you, if you have any type of ventilatory circuits, especially transport vents, that you check with the manufacturer about any of the filters that can be added to that circuit to prevent transmission to the providers that are around them. Bronchoscopy, certainly mechanical ventilation. There are some of the sort of post-mortem things that would be done in an autopsy that can cause that. And the dental practice is really at big risk, especially around ultrasonic scalers and some of the other pieces that they use within that setting. And I can say that when I went to my own dentist office, I was pretty impressed with what they did. I mean, they literally looked like they were prepared for Ebola when I walked in, and the dentist said, we're trying to take this very seriously because we want to keep ourselves open for our patients. I think they got about 3 months behind at one point. And I know here, even in Atlanta, where I live, there's facilities that are already canceling elective procedures as we speak, which is going to, create a huge backlog. So what about, if an employee wants to go get vaccinated, sort of what are the reasonable requirements? There's sort of a lot of misunderstanding associated with this, practically, and sort of, as we're not surprised on the employee side, where people are saying, oh, the employer needs to give me, 10 days off, whatever it may be. No, right? So all they're saying here, though, is that they're really looking at the sort of support structure of the COVID-19 vaccination. So that is something that we really want to think about, right? If you're going to have a setting where that employee is going to be off for a few days, then that's one thing. If they're coming back multiple times, and let's say they're a little febrile, or they just don't feel well following the vaccine, then we want to make accommodations for that, right? And again, it goes back to reasonable time as well, right? So we want to make sure that we're sort of thinking about that, and also the type of setting. One of the other things is that if people want to go get the vaccine while they're on the clock, we want to try to make accommodations for that, or bring the vaccine to them, which is even more of a helpful thing to do. So as far as the amount of time, right, they want you to have paid leave, right? That can be either part of their paid PTO, or it could be something sort of considered as administrative leave. A lot of places have gone to sort of a COVID leave package where, let's say you get exposed, for example, they'll pay you for that time off, right? It can also be in the form of their sick leave, and certainly it can be part of their paid leave as well. The employers do have the ability, I say again, the employers do have the ability to set a cap, right? And so that is up to them, right? So that reasonable expectation. And I think if we look at the data, especially with the adverse event data that's been reported to CDC, we've got a pretty good idea of how quickly these sort of signs and symptoms of the vaccine itself really go away. And my favorite sort of handout that CDC has related to the vaccine is sort of what to expect after. And I think that really helps us get ahead of this curve so that people know, well, if I get this vaccine, when's really the ideal day? Do I want to get it on a Monday when I'm going to work 5 days in a row? Or do I want to potentially get it on a Friday when I'm going to be off for that entire weekend, right? And so generally speaking, they want you to have up to 16 additional hours of leave, right? for any side effects of the dose or 8 hours per dose, right? So that's sort of the minimum requirement that's associated with that. An employer could, of course, go above that. So what if an employee wants to go get a vaccine outside of the workplace or off work time, right? So if they're going to be on sort of paid time, right, then, you know, they can go get those vaccines during work hours. That's fine. And you want to make that accommodation. Some places even cart them over there and go do that, right? If they choose, however, to go get the vaccine when they're not at work, right, then the employer is not required to grant that time, right? And that only makes sense. And I think that's fair for the employer and for the employee, right? So they're not required to grant that time. Now, if an employee receives the vaccine outside of work hours, though, and then let's say that they have a low-grade fever and they're very malaced and fatigued, then we'll still go ahead and give them that up to 16 hours, or if we want to give them longer. So even if they get it outside of the building, that we still want to be, sort of understanding of that. So the next little area I want to cover before we get to the end of my piece and we transition to Sarah is a couple elements related to cleaning and disinfection, right? And we didn't cover this last time because there was just so much content, but this is something that's directly called out in an OSHA ETS standard, right? And really we're looking primarily at clinical areas, but also other areas where people will congregate, right? And so we're going to defer back to the CDC's guidelines for environmental infection control, the CDC's guidelines for disinfection and sterilization, and then their guidance document, particularly for COVID. Now, the good news is that COVID is not terribly hard to kill on an environmental surface. And so we have a very easy time getting rid of it if we simply do good cleaning and disinfection. We also want to focus very heavily on our high touch surfaces, which I'll define here in just a second. And then most importantly, we want to use an EPA registered, right? The Environmental Protection Agency registers all disinfectants in the United States, and it needs to be hospital grade and one that's found on what we call the EPA List N. List N is actually products that are deemed effective against the SARS-CoV-2 virus, which is the cause of the COVID infection. So high touch surfaces, I've got a list here. Don't get hung up on this. This is not meant to be all inclusive. Your high touch surfaces may be slightly different. Sarah's may be different than mine, depending upon the sort of care setting that we're working in. But, you know, think about this in terms of where am I going to touch? Where's the patient going to touch, and where's the family going to touch, or any visitors? You know, think about a visitor lobby bathroom. That's a very, high frequented area. Think about the bathroom of a patient's room. And we know that, for example, the remote of the bed is another area as well. And so we want to clean and disinfect those things at least once a day. Certainly, if those items become visibly soiled, we want to go ahead and do that as well. And then if we become aware that there was somebody there that was positive, and they have been there in the last 24 hours, we want to also do a good cleaning and disinfection of that affected area as well. So as far as how often, right, this is going to be dictated by primarily your policy and procedure, also the manufacturer's instructions for use, but at least once a day. Sort of my rule of thumb is, especially for things that I'm going to touch, I clean that at the beginning of my shift. I clean that certainly throughout the day as needed, especially if it's used between patients, and then I clean it again before I leave. And an added to that would be if it ever becomes visibly soiled, right? That makes total sense that if something's dirty, that we would go ahead and take the necessary steps to do that. But always defer back to manufacturer's instructions for use. And so again, the CDC does have good guidance that's hyperlinked there, so you can download that from the slides. We also want to make sure that if there's areas where, again, someone was known to be sick, that we want to go ahead and clean and disinfect that, but there's really no other special requirements that are needed here. We are seeing sort of the adage of UV light, electrostatic disinfection, fogging, some of these other technologies out there that allow you to get to sort of a larger scale of areas, especially for places like cafeterias or waiting rooms or lobbies, where it just makes sense to sort of get a larger surface area going. The key here is to try to use something that's EPA registered and according to the manufacturer's instructions. There's a lot of different technologies out there that don't have that EPA registration, and therefore we don't really know what the true efficacy is and how that's going to be delivered. We want to follow the manufacturer's contact time, right? And that contact time is that total amount of time that that product needs to remain on that surface in order to inactivate those targeted microorganisms. And you'll find that most often that's usually within a minute or two for most of the products that are commercially available out there as well. And then once that area that might be contaminated is reopened, has been cleaned and disinfected, then we can go ahead and successfully reopen that. So in our third webinar, we're going to talk a little bit more specifically about HVAC. And so I just want to sort of quickly hit on this because there's a lot of misconceptions associated with this. One of the absolute best things that you can do is to work with a qualified company that has technicians that understand healthcare error. This is so helpful, not for just COVID, but things like Legionella and some of the other sort of challenges that we deal with respiratory viruses, right? But it does not require you, the OSHA ETS does not require you to do anything special to your HVAC, right? They want you to optimize it. They want you to have as much fresh air as possible, but there's no specific requirement associated with that. You're going to have to maximize this as much as you can. You know, think about our colleagues and friends out in California that are dealing with wildfires. It's very difficult for them to bring in lots of fresh air because that would bring in a lot of the pollutants from the smoke outside. And so there may be certain circumstances where you don't have control. Right? Think about a physician's practice that may be in an office building, or maybe you're in a high rise or something like that. And all of that sort of system is controlled by other individuals, right? You do want to make sure that you work with that building owner or that maintenance company to help them understand your particular situation with the types of patients you're caring for, the types of procedures you're doing. Maybe you're an ASC, right? And you're inside a larger building. What's important that you have control over that sort of air filtration rate so that you can really directly control that. So it is your responsibility to sort of work with the building owner, but we know that it's not within your scope, if you will. So there are different filters that are available. So the minimum efficacy reporting value, or the MERV scale, is actually going to help us look at filtering efficacy, right? And that's going to really look at 0.3 to 10 microns. Sarah's got a great chart that we'll just show you here in just a second. But we know that those higher values, right, the higher that value is going to look at higher efficacy, right? So that is going to be helpful, especially in our known COVID or suspected COVID areas where we're doing observations. And so if you've got a MERV rating of 13 or greater, then you're really capturing about 85% of those particles, right? And that's really going to be helpful when we think about that in context of COVID-19. And so these are actually the slides that Sarah had added, which I thought were spectacular, right? To just sort of give you an idea of the scale. And what I love is sort of the size of human hair, all the way down to, if you look, it's a little bit hard to see, but you can see coronaviruses almost at the far left, and you'll see that Zika virus is actually the smallest there, right? And so it just gives you an idea of the relative particle size. And again, the size of the filter matters, but it also really looks at the optimization of your system as well. So here's a little bit more of an example as far as the particle size and the efficiency rating in microns. Again, work with a healthcare person that understands HVAC. ASHI and ASHRAE also have a lot of great organizational resources that are available on their website. Many of them have been made free just due to the COVID pandemic, and I encourage you to check those out as well. And then lastly, you can sort of see how this sort of translates with relative humidity. I know every time I walk out of my house, I feel like the humidity is 99%. And so that is going to impact not only sort of the transmission, but also the aerosol capability and potential for these organisms. So if we can, we want to get as much outside air in, and we understand that that's not always possible. And so we want to, however, look at what that optimized rate is. If we can't get a lot of fresh air in, then what are the things can we do? What about HEPA filtration as an example? There may be sort of portable units that we can deploy throughout the building. So with that, I'm going to turn it over to Ms. Sarah, and she's going to walk us through the elements of the plan. And then at the very end, we're going to have her share her screen, and she's going to show you some of the resources that are available. So Sarah, I'll turn it over to you.
Great, thanks. I did want to go ahead and address one of the questions I saw pop up about whether a TEE was considered an aerosol generating procedure. So for the purpose of the OSHA standard, what Hudson listed was all inclusive of what OSHA is considering to be aerosol generating. Now, that doesn't mean that you still may want to provide that higher level protection for your staff. It's certainly a procedure that can involve the airway and those oral mucous membranes and areas where COVID can certainly like us to hang out. So I don't think there's anything wrong with going above and beyond. And of course, remembering that any patient with suspected or confirmed COVID, we want to make sure that they have that N95 higher level respiratory protection for all care activities, regardless of whether they're aerosol generating or not. So hopefully that helped answer that question. All right. Okay, so we're just going to dive into some of the specifics as it's written in that the OSHA standards. So step one, do you need a written COVID-19 plan? Well, probably most healthcare facilities are going to fall into that category unless you are a unique setting where everybody in the facility is fully vaccinated and you're not going to come in contact with suspected or confirmed COVID patients. And on the OSHA website, they do have this nice little flow chart. So if you're unsure, you can just pull up the flow chart, and we'll go on the website a little later. I'll show you where that is, and you can work through that if you aren't sure. So, oh, if you'll go back, Hudson, sorry. And so if you know you need it and you have greater than 10 people in your setting, in your healthcare setting, then you do need to have that plan written. And if you're part of an organization that has multiple facilities, it may be that you can use one plan, but you want to make sure that it addresses workplace specific needs. And all of that's included with the plan. So you just kind of have to look at, it may depend on your setting on whether you need multiple plans or you can include it all in one. So, okay. So a few points, and Hudson mentioned this, is as you do your risk assessment and as you develop the plan, the OSHA standards do very specifically state that you need input from non-managerial employees. So you should really engage some of that frontline staff as you're doing the risk assessment and as you're putting the plans together. And I think that's good practice for much of what we do anyways when we're developing policies and procedures. This is all about protecting our frontline staff, so it's great to engage them. Within your plan, you also need to specifically state who is going to be that COVID-19 safety coordinator. And the requirements are that they need to be knowledgeable in infection control principles and practices, and they must have the authority to ensure compliance. So it might be, you know, your DON, it might be your infection preventionist, you might have an employee health leader, you know, or you may have multiple individuals named within, you don't have to have just one, you can have several people that are identified as that safety coordinator. But it does state you need to say, who is that? And then another point to cover is that this is not only for your facilities staff, but also if you have any contract workers, you need to make sure that you're coordinating with those groups so that there's good communication back and forth between your facility and contract staff, and everything's in line. Okay. All right, so step one, you've got to complete this hazard assessment. When you look at this assessment, you want to look at the workplace setting as well as the specific job role. So again, OSHA has this wonderful kind of checklist, hazard analysis, that there's a screenshot there of it. That helps walk you through this, and we'll pull it up and it breaks it down. It can be a lot. You know, if you're a large facility, you have different care environments, you have different roles, whether it's, you know, environmental services, or it's, you know, a clerk working at the front desk, or a nurse providing direct care, or a nurse working in a admissions office or something. So there can be a lot of different ways to look at this, but this analysis helps you kind of break it down and organize the flow. And it kind of looks at both fixed workstations, so people that may work at the front desk or at admissions that are in kind of a fixed station, and looks at risks in that setting. You know, you may be able to apply barriers there, whereas if it's not a fixed workstation, that wouldn't be applicable. So it breaks it down as that's one section. And then the next piece is if someone has the potential for exposure to COVID-19. So again, this is a wonderful tool that they've provided that you can go through and you can use that. It's already built, and to help you kind of identify those different categories and the interventions that are going to be needed based on that risk assessment. So you'll do your assessment and then. And
Sarah, a question just came in. I think they meant to send to you, but they were asking about, is there any type of retention requirement to sort of hold on to the copy of the hazard assessment for a period of time?
Oh, that is a great question. I mean, you do need to have your assessment available. My understanding is that if OSHA comes on site or an accreditation organization, that they may ask for this and they may want to see that. So I would be prepared to hang on to that. And we'll see, you know, this is a emergency temporary standard. So We'll see if how this flows long-term. But I will, I don't recall seeing any specific dates listed in the standard, but I would definitely hang on to that you'd want to be able to produce that if they come on site. So the elements within the plan, so just some basic components. So you do your risk assessment. You need to be prepared to evaluate for its effectiveness and update it as needed. And then in the plan, you're going to list what you're going to do to address all those hazards. So you do your risk assessment, you come up with a list of hazards, and then within your plan, you're going to describe the things you're going to do to address those. So those policies and procedures within the plan are designed to minimize the risk of transmission of COVID-19, a plan on how to effectively communicate and coordinate with your employees and then employees of other employers, so contract workers. And then as Hudson kind of went over before, it also needs to address if you have employees that are going into private residences or other settings that you don't control. How are you going to protect them in that situation, including describing when you would withdraw them? So if it's a home health agency, and you've described that if that person, you're going to screen those patients, and if they screen positive for potential signs and symptoms of COVID-19, then your policy would be for the home health person then to leave the facility or to not provide care. If that's your policy, then you would need to have that described within that policy and procedure. So, and here in a little bit, we'll pull up the example that OSHA provides that goes through all those specific pieces. They did a wonderful job of putting together everything easy to use. So it makes it very easy. So these are just a list of all the elements. And again, you know, we've kind of gone through this at length on all the different components that need to be addressed. And maybe you already have a lot of this already described or written in other policies and procedures, and you can just reference that. But these are all the different things that need to be addressed.
And I'll just say from experience too, the anti-retaliation is probably one of the most important, especially for this, because it can get you into the most trouble for sure. So there's some great resources on the website that Sarah's about to show you regarding that.
Yeah. So I did want to, I'll flip over and share my screen. I did want to take you all to the OSHA website. I think that this is, if you have not visited the website, I definitely recommend it. If you're going to be responsible for putting these policies together or operationalizing them, this is just such a wonderful resource. So, all right. Okay. All right, Hudson, can you see that okay?
Sure can.
Scroll, okay, wonderful. So this is OSHA's website with the emergency temporary standard. And when you scroll down here, there is just a tremendous amount of resources. So here is the actual standards. And again, I recommend you pull these up and read through them. It is, you know, not exciting reading, but I always recommend, you know, if you have questions, go to the source, see how it's written and the language in which it's written, and at least start there. And they also have all these wonderful fact sheets, just a bunch of information and a webinar that you can listen to straight from OSHA. Again, it's, you know, it's not exciting information, but they've got all of this right here for you. And then on the other side, they have a COVID-19 plan template, as well as the hazard assessment. So if you pull up, you can actually use this to do your assessment. You don't have to, you can use your own version, but it starts out with a nice checklist that just goes through all of the different elements required of the plan. And you can go through and say, you know, do we have this check? Do we not? And need to address it or determine if it's applicable to us. And then as you scroll down, it covers all these different sections here. All right. And then it breaks it down first. Step one, defining the different work locations and job tasks. So this first part here is specifically for fixed work locations, and they even give you an example built in here. So of a reception area, and then the specific risks associated with that. So step one, we're just defining that risk or hazard. And, you know, it may take multiple pages to go through all the relevant job types, depending on the size and complexity of your facility. And then this one is for employees who may potentially be exposed to COVID-19, suspected or confirmed. And it does the same thing here, where you can list the location and job hazards so that you have a place to document that. And then the next piece describes the kind of the controls that would be ideal for each of those. So it kind of goes through that. You can just work through this and then keep that documentation to show that you've complied with that portion. Again, ensuring that you have all key stakeholders, including your bedside staff representative. And then if you click on the plan here, okay. All right, Hudson, did that come up? Can you see the Word document?
No, you just got to switch your screen. If you just put it on, yeah, if you just put it on all screen, it should pop right up, or you can just switch it to Word. There you go. All good.
So they have created this plan for you, ready to go. And it's got the link right here at the top to, do I need a plan? Is your workplace covered by the ETS? And then all you have to do is kind of fill in the gaps as you go. Purpose and scope. It has a place for you to list who your safety coordinators are. And then it goes through, talks about the hazard assessment, and then it includes some of those interventions that you would put in place already pre-written. You can just edit the pieces that you would need to. And so all those components are built there, ready to go to make it as easy as possible for you all the way through. So I think these are wonderful resources that definitely recommend you tap into them that are available. So.
Cool. Ruth, I think you had some closing comments. I know you joined us that you wanted to make before we open it up for a question and answer.
I appreciate both of you. You've done a very nice job. And Sarah, I particularly enjoyed the walkthrough through some of these tools and resources that are available, because, you know, as Hudson was going through a lot of the elements and the questions and the all of the areas of emphasis, it's easy to get overwhelmed. And I think in order to be successful, it's going to be going to these resources and beginning to just kind of step your way through it. And know, as you mentioned, this is still a temporary standard. Now, that doesn't mean it's going to go away. It certainly will not go away, but it may continue to change, or it will continue to change, especially as we look at information, new information, and how we're kind of changing. One of the big examples is how we decontaminate respirators, what the guidance is now for reuse of respiratory protection. Also, I know there's a lot of discussion about the mini respiratory protection plan, and what is that saying, and the acceptance of people bringing their own PPE to work. I mean, there's still a lot of the practicalities, the pragmatic approaches to this standard that are still under evaluation. So I appreciate that you all put this together. This is excellent information. I know you have plans on providing another session, which I think will be really needed as we work together and put this through. And we might even think about, how to start getting just some questions from people that are working on their plans, and what are some of the biggest challenges to make this work. So, and we know that this is a work in progress, and I'm very appreciative of your efforts. Thank you very much. So let me turn it back over to you guys, and we can use in our remaining few minutes for questions.
And I'd love to your point, Ruth, if there's specific things that you'd like included in that third, and we can also add a fourth webinar, to just drop those in the chat for us. And that way I can capture those, and Sarah and I'll make sure that we add those in there. We did the second one based on your feedback from the first one, and we'll do the third one based on the feedback from today. So I think, as Sarah walked through that plan, we're in a pretty unique position with OSHA, in my opinion. They don't normally give us this many tools, right? It's normally go do this, but they don't tell you how to do it or what to do it with. So I think we're actually in a very good position, and you're also very legally defensible if you use their tools to say, if an inspector comes in and they say, well, how did you develop your plan? And you say, well, I used your plan. Well, that's a pretty easy win, right? As long as you then are doing it compared to creating something from scratch. But if there's things that don't make sense or other areas that you want to explore, I think let us know. And I think, Ruth, your point about this is not going away, I couldn't agree with you more. How do we figure out ways to hardwire this? And a lot of this stuff we were already doing in other aspects of our infection prevention and control program. And so maybe that's really the long-term fix, but there's also a big need for this type of standard in the non-healthcare sector, right? Where you've got some, like schools and some of these other environments where there's large congregations of people. So it'll be interesting to see how OSHA does this.
I think too, Hudson, you asked Sarah the question that someone had posed about how long, do you need to keep your risk assessment? Do you need to keep that process? And I think this is, again, another example that where this is all uncharted territory, and we've never had to keep those types of records before. However, because we are seeing individuals who become ill at work, or individuals who are pushing back from some of the safety controls that we're trying to put in place, such as vaccination or universal source control, that we've never had to demonstrate the scope of our planning before. Right. So we very well may have to do that just in response to employee illness that occurs, or, I just heard about this, and some of you may have experienced that. I guess somebody's running around neighborhoods putting things on your doors with a review of that ridiculous German study that showed that kids who wear masks have an increase in CO2. And that, masks are harmful. That clearly was, a bunch of garbage, but anybody can make a hanger to hang on your door. And so somebody may actually believe this, and then may bring back and challenge then what your approach has been. So that risk assessment really is the kind of the roadmap for you bringing the science and bringing the expertise into your facility to help develop these plans, and then any associated training or tools and resources. So it's a new day, isn't it, for all of us?
So it looks like we have a question from Tiffany in regards to staff bringing their own personal protective equipment. I know that CDC has an approved list of respirators. Shouldn't those be on the approval list as well? So good question, Tiffany. So you can always go back to fda.gov and click on the little coronavirus tab at the very top of their website. And they have a listing of all of the different types of PPE that are approved for that use. And you can always write in your plan that it needs to be a medical grade respirator that's FDA cleared. And that way you have sort of that nuance there, because you don't want somebody buying something that is not for medical purposes, that's not going to properly fit. What their OSHA is trying to do is saying if the employer can't provide it, the employee has the right to bring their own, right? And so that's certainly something to do, but it has to be within the context of how they're going to validate that in order to ensure that it's safe. But FDA would actually be the better place to go, because they're the ones that actually the regulatory body for approval of those, where CDC is really giving more guidance on like the reprocessing and things like that, which we're not supposed to be doing anyways.
Yeah, I was seeing a comment, a response to that very issue, Hudson, on, I think it was Shay's response that they were crafting to send back to OSHA, because one of the components is that if somebody doesn't, maybe their job doesn't involve direct patient contact, but masks are made available to them, but they want to wear a respirator. So can they bring their own respirator to work, even though it isn't required for what they are doing? Well, the way the standard reads that they can, they can come in a full body scuba gear with a papper on, right, and flippers and a snorkel if they want, the way that the standard is written. It's kind of that loose. So I think some of these responses were, you need to really have an alignment between what is necessary for the job, and that the individual needs to recognize that more is not necessarily better. In fact, many times with PPE, more is worse than better, and that we still need to put it back in the hands of the expertise that's at the healthcare facility to actually develop those procedures and those policies, and then make sure that they are able to be implemented appropriately.
For sure. And I did.
So don't wear your scuba gear to work. Yeah. So
I know. Well, unless you have your flippers. So I did post the handouts earlier. I'll post those again so that everybody has those. And Sarah and I will also be announcing the date for the third one, but we'd really like to hear from you if you've got any specific items that you'd like included in that. I think our thought is to go through HVAC, the anti-retaliation piece, the record keeping and reporting for the next one, because those are sort of the final elements of the ETS that require a little bit more time than the hour that we had here today. So are there any other questions or comments? Ruth, anything else that I don't see any other in the queue on my end.
I think everybody's trying to think. I know in your head, it's like, how am I going to do this? And I think how we do this is going to be, very important. And I think it will really be very beneficial if we can rely on each other, and then, share things that we're developing, what works and doesn't work. And certainly our first big issue is developing our risk assessment and our plan. And then how are we going to train our staff? That's going to be a big challenge, and trying to get people on board with what we need to have done, and standardizing what we can do and being consistent. So we're all going to be learning about this over the course of the coming months. And I have to feel like if we are able to improve our overall infection prevention and control, then once we get on the other side of this, that we will be better for what we have done. It's just, I guess that old adage, when going through hell, you got to keep on going, because, you'll come out on the other side. And I think that's what we'll do if we're working together on this. So thank you, Hudson and Sarah, for excellent review today.
And I see a message from Glenda. My director of maintenance is sitting in the office and is listening to this presentation. He's been through an OSHA inspection with me. So Glenda, I'm sure you can agree that that is a very, very painful and trying experience, right? It produces gray hairs for sure. I'd rather have Joint Commission come than OSHA for sure. So what was the outcome of your inspection, Glenda, if you don't mind sharing?
It's been some time ago. I think I shared it on one of our other sessions, Garrett, that we're on with you with University of Louisville. But I think the biggest thing that we got was that he was constantly on everything we were doing. All of our eye wash stations were they were all being blocked by housekeeping carts. You know, they weren't the right amount of water. It wasn't fresh water. You couldn't turn them on without touching them. He went off on us, our paint storage. He went through everything especially in our maintenance department, but he went through everything in healthcare. But biggest thing I think we were cited on was eye wash stations, and we had a couple of chemicals that we didn't have the SDS sheets for, I think, on our housekeeping cards. You remember? Yeah. And of course, one of our housekeepers had gone in and taken her lunch and set her Mountain Dew up on one of the shelves where we store chemicals. She had eaten her lunch, and then when we called her, OSHA had come in. She left it all in there. Of course, you know, we recited over that. I don't remember, but I hope they don't come back because we're so long overdue for surveys. But anyway, yeah, I'm through.
I think, they're going to be focused on the big ticket items, the things that truly are associated with harm for the employee. So I think that, that we're going to have to make sure that we've got the main components in place. And we know that this is going to be an evolving, go back to, remember when we worked to implement the bloodborne pathogen standard, it's not a simple, at that point, it was not a simple thing to do. If you remember, we hung plastic on everything because that's what we thought the standard meant for us to do. And then we began to figure out that we can't possibly work and get the job done. So we began to figure out how to exist with the standard. And so that's what we'll go through with this. The important thing is going to be whatever we're doing, remember that we're trying to make sure that we're keeping our healthcare workers safe. So those things that we know that have reasonable evidence behind it, those are the things that need to be non-negotiable. The other things where we're not so sure, maybe those can be, part B that we start taking care of. Or I saw a question somebody had about changing from KN95s to N95s.
So you would go back to the 3 levels of PPE contingency. So right now we're in a conventional operation in most places. There may be a few places that are sort of in that contingency mode. So if at all possible, you would want to, wear an N95 if you can, if you're wearing a respirator, one that's going to be FDA cleared. There may be other masks that have FDA clearance as well. Only in times where you cannot obtain that should you be wearing a non-FDA cleared mask. So they put out some pretty good documents about that. Let me see if I can get the link real quick too to post that's got that.
Yeah, because remember, KN95 is not a respirator,
correct,
not for our general use. And N95 is a NIOSH certified respirator. KN95, even though it has N95 in it, it is not NIOSH certified. And that was the best we could do for a while. But please don't rely on those and think that they're going to be as effective as an N95.